Welcome to the Cafe Culture podcast, a season of discussions on culture, politics, philosophy and science.
At a talk recorded on the 21st of October 2013, Chris Graham discussed healthcare as seen through the patient's eyes.
Okay. Firstly, thank you very much for the very kind introduction, and thank you to the organisers for having me here tonight. Very pleased to be here to speak about patient experience in the NHS and the role of patient-centred care. It's a topic that's very dear to me, both in a professional role and a personal role. I, like many people, feel greatly indebted to the NHS and greatly fortunate to have such a proud and prestigious service that we can access. I'm going to talk about a few things tonight. I'm going to focus mainly on the role of patient experience in this concept of person-centred care. I'm going to talk about how it's developed over time. I think what's particularly important to reflect on is that this is a relatively new concept. The idea of measuring patient experience, the idea of putting people at the heart of healthcare, has only really evolved over the past 20 to 30 years. And what I want to do in telling the story of person-centred care and patient experience is to trace some of this evolution back, look at where it came from and look at what it's kind of replaced over time. Where we are now is a place where person-centred care and patient experience is tremendously important, tremendously visible. We see that not only in the very large initiatives of the current government, like the Friends and Family Test, which we'll talk about in a bit, and people may have encountered that already, may have opinions on that. It's already very controversial, despite only being 6 months old. But also patient experience is very prominent in criticism of the NHS around failings. For example, the Mid-Staff's investigation, which published earlier this year into problems at one hospital trust, focused very prominently on the experiences people had there. But how did we get to this point? How did we get to the point where experiences matter as much as safety and outcomes, matter as much as life or death, and matter as much as things like access, hygiene, and effectiveness? Let's follow that evolution a little. And I think every story should have a beginning, a middle, and an end, and equally every story should have a setting. So let's set the scene a bit. The setting for this story is the NHS. The NHS is one of the world's largest organised healthcare systems, and certainly one of the world's largest organisations to boot. It's been a pioneer from its inception. In 1948, when it was established, Anya and Bevan said that it gave the UK the moral leadership of the world. It was new, it was bold, it was thinking that it set us apart from what anyone else was doing. And we've continued to be a pioneer since then. From the 1960s, completing the first successful full hip replacement, through to the 70s and 80s, leading the way on IVF. In 1987, just down the road at the Freeman Hospital, the first successful full heart transplant on a baby. It's an incredible history of pioneering within a public service that's funded entirely from the public purse. And that funding is considerable. Today, over 100 billion a year goes on the NHS. That's almost 10% of GDP. As well as that, 1.7 million people in the UK are employed by the NHS. Now, that's about 1 in 25 of the adult workforce. That makes the NHS the 5th biggest employer in the world. Only the US military, the Chinese military, Walmart and one other are ahead of it. I forget the 4th. But it's clear we have this tremendous enterprise, tremendous in its scope and complexity and in the range of organisations contained within it. And that's really important for understanding some of the bits of development that we'll talk about tonight. More than anything else, though, as much as we can talk about the numbers and the size and the scope, I think it's clear that the NHS is a source for national pride. It's a national symbol. I mean, this was embodied in the Olympics opening ceremony last year, where Danny Boyle's opening spectacular had a very prominent focus on Great Ormond Street Hospital's nurses and staff. It put the NHS on the world stage, and the reception to that was evident. Now, 71% of people still say that the NHS is one of the best in the world, and that speaks to the veneration that we have for the service. In the 1980s, the Tory Chancellor of the Exchequer, Nigel Lawson, said that the NHS is the closest thing that the British have to a national religion. Now, as I say, there's a degree of veneration, and I think polling bears this out. 89% of people say that they tend to trust doctors, makes doctors the most trusted profession in the UK. By contrast, you've got 82% trust judges, 65% trust the police, 23% trust MPs. So if you stop a random person on the street, they're about 4 times more likely to trust the medical profession than to trust their elected member of parliament. I think that's incredible. Incidentally, 50% of people trust pollsters like me. Now, people tend to forget the second part of Nigel Lawson's very famous quote about the NHS. If the NHS is the closest thing we have to a religion, he said, then the people who practice in it regard themselves as a priesthood. Now, it's important. Any priesthood has got to have its codes and its rules. The word doctor, in fact, stems from the medieval Latin for church leader, and there's always been this sort of religious connotation to the role of medicine. The role of the patient, I think, is very different. If you trace the etymology of the word patient, it goes back to, again, medieval Latin, but the word pati, which means to endure. But not only to endure, but to endure with composure, to be passive, to be in receipt. And that thing of passive receipt has remained important. It's been part of the doctrine of health services throughout the world for a long time, and it's been something that has come to be embodied by what we now call the medical model. Throughout the 19th century, medicine as a profession advanced tremendously, in particular through the discovery of germ theory. Out went ideas about the miasma and about toxins spreading through the air and making people sick. Arguably for the first time, we really started to understand where ill health came from, where pathologies developed, and how they could be treated medically. What this meant for medicine as a profession was that medical expertise became exceptionally valued and exceptionally respected. And this form of medical profession placed a great deal of emphasis on signs, symptoms, pathologies, and diagnoses. Patients present with physical signs and symptoms of illness. They are a gateway, a clue to what's wrong with them in a physical sense. Now, that doesn't necessarily include much consideration of biosocial factors or a person's lifestyle or personal circumstances. It's really about physical pathology. And that's important because that places the patient in a role where their duty is to comply. They need to be submissive to the expertise of the medical professional, and that is their role in it. I think it's interesting that I describe this as the traditional medical model. We didn't actually have the term the medical model until 1971, and it was coined by the anti-psychiatrist R.D. Laing. Laing was interested in mental health in particular and the diagnosis of some mental health conditions, and particularly psychosis. And what he noted there was that the traditional medical model broke down. One couldn't simply look at the physical causes or results of conditions. One had to look at patients' behaviour. And that contrast to the medical model necessitated a different approach to engaging with patients and involving them in discussions. The medical model itself really separated patients from knowledge. It had a paternalistic approach where, in some ways, patients were almost like children. You would go and see the doctor would tell you what to do, you would accept that and move on. And the study of interactions between doctors and patients stressed that this kind of paternalistic approach was retained. Doctor knows best, is the summary. More recently, philosophers have looked at this and questioned, why are we so willing to subsume ourselves to the will of medical professionals? Why do we allow ourselves to be in that position? The philosopher Javi Carrel talks about this in terms of the innate epistemic injustice of medical consultation. Now, what she means about that is the injustice in the knowledge relationship, the inherent denigration or the unspoken denigration of the personal knowledge of the patient receiving treatment versus the medical knowledge of the professional. Now, that can sound glib, I think, because doctors do have a professional knowledge that patients shouldn't be expected to have. But what they don't have is the lived experience of having the medical condition, the lived experience of the impact on life. And a model that devalues that relative to the medical diagnosis is one that will inherently fail to capture the patient's life. What changed? Why not continue with the medical model? Now, the NHS, much as it's a source of pride, has unfortunately been no stranger to scandal over the last 20 to 30 years. Alderhay, Bristol, Harold Shipman, Maidstone, Tunbridge Wells, Mid-Staffs, the list goes on. We can recite these NHS failures. when they arrive, they're high profile. They draw attention, they're the subject of intense debate, scrutiny, and dissection. The Bristol heart surgery scandal is a particularly important example because it marked a sea change in the way that professions thought about their relationship with patients. For those of you who aren't familiar with what happened, in a nutshell, an inquiry in the mid-90s found that Bristol's hospital's heart surgery unit, performing surgery on babies and young children, had employed a number of clinicians with very high mortality rates. They were far more likely for patients to die than other hospitals or with other consultants. An inquiry in 1998 was damning. It found that contributing factors to these high death rates included an old boys culture amongst consultants, a protective culture and way of thinking that defended the consultants in the medical profession and neglected patients. It found secrecy regarding performance. These numbers, these statistics about the experience of parents and the outcomes for patients were kept hidden, and children died. Writing in the BMJ at the time, the journal's editor, Richard Smith, invoked the words of Yeats in describing the impact of this on the service. All changed utterly. He said that there could no longer be this blind, passive trust on the part of patients and the public towards the medical profession. Something had to change. There had to be a system of active trust, something new, where patients were participants. Now, I'll talk about that a bit more. I'll say the heart surgeons, we've given them a hard time, but we'll come back to them later and talk about how they've responded in their own way to the Bristol scandal. Now, if we move from this system of passive trust to active trust, and we move away from the medical model, what does that mean? It means a new approach to consultations, it means a new approach to care. And there had been some efforts around this in the past. The Ballant model in the 1960s is one example, but none really caught on until the 1980s and 1990s when person-centred care or patient-centred care began to emerge in the United States and also in the UK. This was perhaps best exemplified in publications such as Through the Patient's Eyes by Margaret Gertes and colleagues in 1993, where a lot of work was done to really explore what person-centred care meant to professionals, but also to patients and to users and relatives. Gertes and colleagues realised that systems that tried to ignore the views of patients or that tried to make best decisions on medical basis alone would inevitably get things wrong, and with the best will in the world, they simply wouldn't catch the needs of users. Instead, they chose to focus on patients as active participants in healthcare. They promoted a system of whole-person care, where social factors and psychological needs were just as important as the physical health, the signs and the symptoms that people presented with. Coordination and communication were presented as equally important. People had to be kept informed and kept involved throughout the medical process. Importantly, one consequence of person-centred care was around who judges the standard of care. In the past, health services were judged on medical outcomes, the number of successful procedures. They were judged on activity, the number of operations performed, the number of people treated or discharged. And they were judged on access, how long people waited to receive services. But patient-centred care as an ethos demanded a new kind of measurement. It said the only way you can judge the standard of care, if person-centredness is part of it, is to ask people receiving the care what they thought of it. They have to be involved in that judgment. No one else has their perspective. And so, both the US and the UK moved to start measuring patients' experiences of healthcare. In the US in the 1980s, this focused on the concept of patient satisfaction, which I think is fundamentally quite a consumerist approach. The idea of asking people if they're satisfied with the care they received almost seems to me to suggest that they could choose to receive care elsewhere if they wanted to. In the States, indeed, they can. And it almost suggests to me that they would vote with their feet if care was poor. In fact, patient satisfaction didn't really catch on in the UK, and there were numerous problems with it that made it less useful. Not only is it consumerist, which in the UK we tend not to like associated with our health service, there were big conceptual gaps. Satisfaction is vague, it's multiply defined. You might know that you're satisfied with something, but if you don't know why someone's satisfied, it's very hard to change anything about it. Perhaps it's best to give an analogy, and since some people are dining around me, let's go with a restaurant. If you run a restaurant and you want to know how satisfied your diners are, or how good your service is, you might ask them. But if you only ask about satisfaction, then there's nothing you can do to improve the service for those people who go away dissatisfied. You don't know if it was the waiting staff that were the problem. You don't know if it was the ambience. You don't know if it was the quality of the food. You don't know if it was something about the parking or something completely unrelated. You need to ask more detailed questions, and you need to find out what matters to people about the dining experience. So it goes with restaurants, so it goes with health, it would seem. And in the 1990s, social research has moved towards the idea of patient experience, to focus not on this kind of vague, subjective kind of satisfaction, but rather on measuring specific reportable events. Asking people, did this thing happen to you? Rather than, what did you think about the things that happened to you? So as an example, sticking with our restaurant analogy, you might establish that attentive service or being seen quickly was important to you. You don't want to wait half an hour before someone takes your order. Patient experience model wouldn't ask if you were satisfied with the service. It would ask how long you waited from the point of arriving at the restaurant to being seated, or to having your order taken, or to being served. Getting the results back as a restaurateur, you can do something with that. You can pinpoint the area where people's experiences are poor, and you can act on it. So that's important. Another important part of patient experience is that patients aren't asked to rate professional skills as such. Now, one of the criticisms of asking patients about the quality of healthcare is, how are they to rate it? How are they to judge? They don't have the medical experience. How do they know what a good consultation is versus what a bad consultation is? Well, the ethos of person-centred care is that this doesn't matter. You might not know whether medically you've received the right treatment, but you certainly will know whether you feel listened to, whether you've been treated with respect, whether you've been given enough time. And it's probably just as bad for you if you feel like you've been treated very badly by a consultant or by a doctor as if you've been given a wrong diagnosis. Because if you've been treated very badly, even with the best advice in the world, you might choose not to follow it. And in fact, there's very good evidence that the worse a person's experience with healthcare, the less likely they are to follow medicine's guidance through to completion, the less likely they are to re-attend GPs and consultants as needed, and the more likely they are to have negative health outcomes. So this is really important stuff. Now, I said at the start that the UK has been a pioneer, and this is true with patient experience as well. We became in 2002 one of the first countries in the world to launch a comprehensive patient experience survey programme, which we still have today. The National Patient Survey Programme covers an increasing range of specialties. Most notably, there's a general hospital inpatient survey, which covers around 140,000 people each year. Alongside that, there are specific surveys covering accident and emergency, outpatients, maternity, general practice, and so on. These surveys are designed to provide high-quality data with a range of audiences in mind. Firstly, the public. They're intended to provide information that should be accessible about how services are likely to treat you. Although in practice, we can talk about whether that information is truly accessible to the public at the moment. They're intended to provide information for services to improve, and crucially, they're intended to provide information for regulation and assessment. Now, I mentioned at the start, we have a very complex ecosystem of different organisations within the NHS. In the hospital sector, for example, we have around 165 different organisations providing hospital services. The way the National Survey Programme works is that each of these organisations will receive detailed feedback about its own services. But not only that, they'll know that the surveys have used a standardised methodology and robustly tested design to ensure that the results they get are comparable to other hospitals, even though they might have a very different case mix, a very different set of patients, or they might operate on very different people. So that's important. In conducting these surveys over time, we found a lot of interesting things. We found some things that have surprised us. We found some things have changed and improved, and we found a lot of other things have stayed the same. Some of the surprises have been where there hasn't been any concordance between what patients experience and what the medical profession thinks it knows, or what regulators think they know. A really good example of that is around GP access, the 48-hour target. Now, many of you will remember a few years ago, if you wanted to get a GP appointment, the only way to do it was to ring a GP first thing in the morning. Does anyone have that experience? Yep. Okay, me too. Now, that happened out of a very well-intentioned plan to make sure that everyone could see a GP urgently if they needed to. The government of the time, or the Department of Health rather, instituted a requirement that appointments should be available within 48 hours for 97.5% of people who wanted them. Turns out that's very hard to provide if you're a GP practice. It's very hard to manage demand in that way. But there's a simple workaround. If you make it impossible to book an advanced appointment, and all appointments are booked within 2 days, then it's very easy to game the system. And that tricks traditional measures. It tricks measures that involve ringing up a practice and asking them when your next appointment is. It doesn't trick patients. And it was through asking patients about how they experienced accessing general practice that this discrepancy was found, and services were changed. The 48-hour target was relaxed, and a new target around advanced appointments for those who needed them was brought into play. So hopefully as a result of that, it's now a little bit easier to see a GP when you want to rather than urgently. There have also been big improvements in things where we've seen national funding, so around superbugs and hospital cleanliness. A lot of money was poured into that, and that's been very visible in patient experience. People are more likely to report doctors wash their hands, more likely to report seeing alcohol gels or hand washes on the wards, and so on. So we can track the impact of policy. We can track how that changes things. We can also track where things haven't changed. What things that haven't moved in the last 10 years, for example, include the percentage of people who don't always understand the answers that they get from hospital doctors. 32% at present. It's barely moved. Likewise, only 55% of people feel that they're definitely involved as much as they want to be in decisions about their care and treatment. Only 55%. So 1 in 2 people who go into hospital will want to be more involved in their care than they are at present. Now, the NHS does a lot well, but I think that's shocking. I think that's something that really needs to improve, but we've seen very little movement on that. We also find that 25% of people don't fully know the purpose of their medicines when they leave hospital. They go away not having been told why they've been given a certain medicine or what it's going to do. Now, that's bad enough in terms of the way people are treated, but the implications of it are tremendous. As I said, if you have a bad experience, you're less likely to follow your prescriptions. And if you don't know why you're prescribed something, it turns out you're twice as likely to have what the medical profession calls an adverse drug event, i.e. you take an accidental overdose or underdose and you end up back in hospital because you've poorly managed your medicines. So patient experience surveys provide a really important insight into these things. They provide a different perspective on the way services operate and the way people interact with them. Now, policymakers in the UK have been excellent about taking this up, and for the last 10 or 12 years, we've seen a wave of policies that have really stressed this, from the NHS plan in 2001, which talked about putting patients at the heart of healthcare, through to Darcy's review of the next stage for the NHS in 2009, which took the really quite bold step of saying patient experience is now equal as a part of quality with safety and clinical effectiveness, giving it a prominence that it had never truly had before. Through to the more recent Health and Social Care Act, and through to current reviews like the Mid-Staffs Inquiry and the Berwick review into NHS quality. The overriding message coming out of all of those policies is that we need to hear every patient voice, even the quietest, and we need to find ways to get the user perspective into healthcare. I think surveys are just one way of doing that, and I don't want to sound too much like I think that the only approach to hearing patient voice. It would be remiss not to note that every interaction with the health service is an opportunity for the patient voice to be heard. Following the person-centred care model, every interaction is one where professionals can hear what people want, can listen to what they need, and can bring their perspective into the consultation. There's a new initiative called the Friends and Family Test, which, who's heard of the Friends and Family Test? Can I have a show of hands? Okay, so I'm going to say about 10%, maybe 15% of the people here have heard of the Friends and Family Test. Now, this is a new initiative. If you haven't heard of it yet, you'll hear about it next time you go into a hospital. From April this year, everybody who leaves a hospital having been an inpatient or having been an A&E attendee is meant to be asked one question about the service. which is, would you recommend this ward to your friends or family if they needed similar treatment? It's controversial. It's derived from loyalty theory in the US around how services grow and how they develop. And there's been a lot of question in the UK over whether it is a valid measure of NHS performance and whether it provides comparable information to different services. Now, I could and I have talked for many hours about this, so I don't propose to do it now. It's perhaps too far into the vagaries of health policy, but catch me afterwards if you want to discuss. The stated aim of the Friends and Family Test, though, and the area where I think it can have benefits, is around culture change. It's around putting patient experience at the forefront of people's minds. It's around getting everyone involved in services thinking about not only how effective is the clinical care I'm providing, but how good is the experience I'm providing. And what I'd really hope to see is data from that being provided at ward level to people providing services on a really regular basis. Time will tell whether that happens. There are also a range of other services available that provide different insights into patient experience. A really good example is the website Patient Opinion, www.patientopinion.org.uk, which provides a forum for dialogue with health services. Anyone who's used health services or a relative of people who've used health services can log on and leave their story. It's not about ratings or assessment. It's just about describing in your own words what happened and what could have been improved. And good organisations will respond. They'll tell you what they're going to do about the story you've described, and then they'll come back and tell you what's actually happened about it. So it's a really nice way to make it a dialogue and engage people. And I think that forms part of the overall package. In the future, we'll see more and more focus on patient experience, and we do need this kind of plurality. We need these kind of big patient experience surveys that provide robust quantitative data. We need the kind of narrative stories of patient opinion and the individual interactions of the health service. We need all of those working together in harmony to really understand what people think of services and how services can be improved using those experiences. In the future, I hope we'll go a little bit further too in terms of where we can regulate and where we can assess. And I want to come back now to the heart surgeons. We talked about the Bristol heart scandal and the very damning judgment of heart surgeons in Bristol. The Society of Cardiothoracic Surgeons has been one professional group that's really embraced person-centred care and patient feedback in a tremendous way since then. Very recently, they published something that nobody else has done as a profession. They published ratings for every one of their members on both their mortality rates and their clinical outcomes and the experiences of patients who used them. So they went and asked patients for every heart surgeon in the country about the quality of care they received, and they made that all available. Good or bad, doesn't matter. And I think that's tremendous, and I hope to see more specialties and more professions doing that in the future. Incidentally, one of our local hospitals in the North East is also doing that, Northumberland, or setting a really good example. They present individual consultant feedback at their hospitals in Wansbeck and elsewhere, so that's the North East leading the way. I'll wrap up there. I'll just kind of sum up a bit. We've talked a bit about the past and about evolution. We've talked about the medical model and the role of patients. Really, this is a story about how patients have changed over the last 65 years, from the inception of the NHS, from being its subjects, from being its passive recipients, to being its involved and active participants. Now, really good person-centred care shouldn't make that a requirement of people, but it should give people that option. And it should put the onus on health services to find out how people want to participate in their healthcare and give them the opportunity to do so. So person-centred care creates those opportunities. Patient experience enables the system to measure and understand how well that's happening. Ultimately, I don't think patients need to assess the technical quality of care, but what they can assess is, for me, just as important. It's the softer side, it's the interpersonal side. It's the relationships and the interactions which make up the bulk of the health service and make it what it is today. And I'll stop there. Thank you very much.
Cafe Culture North East is supported by Newcastle University, Peels and the British Science Association. We're also supported by Ginger's Cafe in Dance City, who host the events.